Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. This is our fourth segment on the quality issue of medicine, and I'd like to invite back our four panelists that have appeared on our previous show for further discussion on this important subject. At the last, within the last show, we mentioned the patient satisfaction criteria or factor in terms of defining is one of the many elements of quality medical care. Why don't we, maybe Dr. Swanberg can give us an idea as to how that, I'm sure they have surveys of patient satisfactions, and maybe can give us a rundown as to what you have found out.
One of the things our health plan looks at is three things that we look at in terms of outcomes of care. We look at the clinical outcomes, did the patient get better? The economic outcomes in terms of how many visits did they need to go to the doctor in order to get better? Did a doctor order the appropriate tests? But the third thing we value is patient satisfaction in terms of the patient's perception in terms of access, quality of care of the provider that they saw.
Right. And I was interested in finding out whether you have any resources allocated for patients' education. Because the reason I'm saying that is because sometimes the patient's perception of what is quality can be very subjective. I have had encounters with patients who think that, for example, if a doctor prescribes the latest antibiotics, then it's good quality medical care, you know. So, and that is not necessarily cost efficient or even scientific. Does your plan have any kind of resources allocating in informing the patient about those issues?
Yes, we do. One of the things we look at in terms of patient education is health prevention and promotion. And we have a series of newsletters that we put out talking about wellness and health promotion. We also have a number of brochures that we can send out to our members concerning a variety of conditions and their medical problem and how a physician might appropriately treat that issue.
Do you compensate the physician's time for trying to change patients' lifestyles and so forth?
We consider that part of the office visit, that when you go see a physician, that they should be counseling you in terms of preventative health care, and our health plan does pay for preventative visits, for physical exams, wellness promotion. But we hope that doctors do that as part of their general office visit techniques. If someone who comes in with bronchitis who smokes, I would hope that they would talk about smoking cessation in part of the 10 to 15 minutes in the doctor's office. Besides giving the antibiotic that they think is most appropriate.
Yeah, I'm very glad to hear that, because as we know, most of the problems in our society are very much related to lifestyle, be it cardiovascular disease, coronary artery disease. You know, Dr. Dean Ornish is promoting a diet plan that has been around for thousands of years, but he feels a vacuum, and he's a star now. You know, I mean, there's nothing new about his vegetarian based diet, but those are the things that to me are very encouraging, you know, in terms of a health plan, you know, that promotes that, because you know, for a long time when I was in practice, that was not compensated. In other words, you compensated to treat or to order tests, but you're not compensated to educate patients or to motivate him to change his lifestyles, you know. Dr. Zammuto, I'm very impressed by the way, you know, I mean, medicine is very competitive, you know. I mean, patients are difficult to get, but you have an excellent reputation as a family practitioner in Fremont. Say if a physician comes out and would like to go into similar kind of practice that you do, what kind of advice would you give for him to build his practice?
Well, I think that obviously the choices of how you practice medicine in 1990s is much different than when I practiced in the beginning of the 1980s. I started out as a solo practitioner. Now the days of solo practice are almost impossible because of the financial burdens that are placed upon the individual physician. And I think that for a resident coming out of family practice, that the most stable environment is in a group environment. And that way there's a sharing of overhead expenses, there's a sharing of call, there's, I think, quality of life issues that physicians can have the kind of life that they would enjoy living and still practice medicine. So I would say that they should look for a group-type practice and look for a practice that allows them the ability to practice medicine in an environment that's conducive to the needs of the patient. Quality has been defined many ways, and one of the things that I've seen in the past in various lectures was quality is outcome divided by cost. And one of the issues is in managed care, are you providing more care, less care, or adequate care? And if a physician feels that there's someone looking over his shoulder telling him the do's and do nots of how to practice the art of medicine. Because as you mentioned earlier, many people are in various residency programs are learning the science of medicine. But it's the true art of medicine that you begin to develop out of your training programs that allows you to sort of finesse yourself in each relationship with each patient so that every patient has a specific approach based upon the factors involved, so that you tailor-make the approach to the patient as well as the treatment to the patient. So a physician has to feel that in that environment that he's able to practice the art of medicine as well as the science of medicine.
Yeah. If you have to pick an associate to join your group tomorrow, what criteria would you go by?
Well, I'd first want to find someone who I can talk to and can talk to me. Someone who I enjoy being around, because I find that if I feel nervous and tense around a colleague, chances are it's because they're nervous and tense.
So
Take
true.
our own pulse first, I think is the answer. But someone who is excited by people, someone who's excited by seeing a patient, whether it be for a cold or for a true life-threatening disease. Because to the patient,
Yeah.
doesn't matter what they have, it's
Very true.
important to them.
Yeah.
And we can't belittle a patient to say, well,
That's
why are
very
you here
true.
just for a cold? Because to them, that may be the most important thing in their day.
Yeah.
We have to respect that.
Yeah.
And I think that lastly, someone who has a reality of what life is. I know sometimes residents coming out have sort of a glorified vision, sort of a glorified financial picture of where they're going to be, but they need to have a reality check. They have debt coming out. They have responsibilities to their families and to their debtors, if you will. So they have to have a real-world perspective about how to make it. And I think that that's one thing I've noticed in some of the recent graduates is sometimes they have sort of a glorified vision of what life is going to be like. Once they get out there, they become very discontent and unhappy because it's not what they thought they should be getting.
Yeah. Yeah. It's hard to to get burned out in medicine after so many years. I mean, what is your secret? I mean, you've been around for a very long time and you still have your smile on the face.
Oh, I find it extremely rewarding, very exciting. I think there's always something new in healthcare. The problems of yesterday are not the problems of today. I mean, I remember a time when people weren't worrying about how many pieces of equipment they used, or and they were surprised, I believe, by the idea of the patient being the customer. I remember the first time we taught CQI at O'Connor Hospital, the nurses were irate when we called the patients customers. They were patients. So that whole idea, has just evolved. So one of the things that you were saying that made me think a little bit more about some of my concerns about today's healthcare is patient education. With the short hospital stays we've got, I worry a lot about what the patients go away with, because we used to be able to spend, talk about changes in healthcare, we used to be able to spend a lot of time with patient education. And new mothers, for example, you know, now they're there for such a short period of time. How do you teach them all they need to know before they leave the hospital? So you have to come up with innovative ways to deal with that. Now we send a nurse to their home after they go home and have them follow up and see how they're doing and teach them there. Years ago, that wouldn't have been an option.
The reason I'm really impressed by your presence is that, you know, I personally have not met too many happy people in medicine anymore. People are full of apprehension. Is that? I mean, do you think that's the case? Or, I mean, do you think a lot of? Because to me, when people like what they do and are well motivated, then the quality goes by without saying. I mean, you need training, you need all that, you know. But when you have the motivation and the energy and the enthusiasm, then the quality probably would emanate from there. But when people are unhappy doing what they do, I don't know how they can provide quality product.
Well, I don't see a lot of unhappy people providing care. I think what I see is a lot of apprehension about where we're going. People are comfortable with where they've been. And things are changing very, very quickly. The public has a whole new perception via the media of what healthcare should be. And in fact, you know, I think we as healthcare providers, and I personally find myself among the happy ones. I'm very, very happy with healthcare. I think I've contributed a lot, and I think I have a lot to contribute. And I think that the newer people coming in, I can help them learn the ropes a lot faster. And I just think that perception of apprehension, it can be misconstrued as unhappiness. I don't believe that a lot of people are unhappy. I think that a lot of people are worried. There's been a lot of financial changes with physicians, I believe, hospitals, a lot of downsizing, a lot of restructuring, whatever you want to call it, that everybody doesn't agree with.
Let's take the devil's advocate here. You know, we're talking about a revolution.
Yes.
That's what I hear a lot. When you talk about revolution, you assume that there's a failure of both the system and the leadership. I mean, do you agree on that? Otherwise, you know, I mean, there should be a status quo. If there's a revolution, the system fails and the leadership fails. I mean, do you agree on that or not? I mean, I'm serious here. So, I mean, that means that, you know, we have, for example, what I'm thinking about the fact that, let's take cancer. You know, we, for a long time, spent a lot of money in research of cures. When we know that 35% of all cancer are related to cigarettes, another 15% to alcohol consumption, and another 30% to high-fat food. So we're talking about 75% are preventable causes of cancers. What do we do for prevention? I mean, we put all the money into research for cures. We don't have too many cures still. You know, those are the things, to me, statistically are very significant. Another thing, 300,000 angioplasties annually are not necessary. To me, that means revolution. I mean, I'm glad that you're happy. You know, I'm glad that you so, keep your enthusiasm.
Me too.
But I often get very you know, frightened by those very things.
I don't think, I believe that you're right about the revolution. And I believe that it was time for a change. And I like to go with the flow in terms of looking at the ways we can change that would produce something a little bit better than perhaps we did in the past. I don't see it as a bad thing. We used to do dialysis, one dialysis nurse per patient, right? When they said to us, look, the costs are too high, you're going to have to change, our initial reaction was, you don't know what you're talking about, you're not the caregiver. We're the ones that have to set up the patient, go get the patient, set up the equipment, etc. But we found out you could do 2 patients, one nurse can do 2 patients, or can dialyze 2 patients very efficiently. And unless somebody says the status quo has to change, and unfortunately somebody did, have to say that. I mean, I think some professions might be a little more, self-motivating that way, but I think healthcare had to have somebody come in and say there needed to be some changes, and I'm glad that happened. I don't think, though, I worry about going too far.
You can say
Well,
something.
I was just thinking about what caused the change in medicine, because medicine in its very beginnings was an art. And I think where the system has failed is when the art of medicine was lost to the technology of medicine. And it wasn't until technology began to take over medicine, the new scans, the new surgical procedures, the new toys of medicine, as some people call them, that the technology brought forward a plethora of techniques and the need to advance the techniques and a need to computerize and mechanize medicine. And so what happened was we had patients in the intensive care unit, and we were looking at the monitors and looking at the readings and looking at all the x-ray results, but we forgot to look at the patient.
Yes, exactly.
We forgot to look at the patient, and we forgot to have an accountability. An accountability to what we're doing, and what the revolution now is about is to bring back an accountability to what we're doing, to try to re-educate doctors, to bring back the art of medicine, to listen to the heart and lungs rather than let's get an x-ray or a scan about what's going on. And I think that that is the whole focus and growth of where we're going is bring back the art, make a true a way of being accountable and justification for what you're doing.
Yeah, I think the revolution has been stirred by economic chaos, because we spend so much money in the wrong place. That's exactly the point I was trying to make. If we turn around and spend money on keeping people healthy, then we don't have to spend so much money.
Right. I think what we're talking about, and I refer to it as front-end cost and back-end costs, is if you spend a little bit more money on the front side of prevention or screening, then you end up spending less money on the back side, where you're spending time trying to treat disease, attempt to cure disease, whether you do or you don't, just time will tell, and trying to pick up all the pieces of a disaster that could have been preventable had you stopped smoking, had you lost weight, had you changed your diet.
Actually, I was trying to find a little poem that was just published. I couldn't find it. Oh, here. Maybe one of you. I really enjoy talking to you so much, Joe. I really am very moved because I agree with everything you say, and I just had this little poem here published in the Santa Clara County Medical Society bulletin. Can you read it for us so we can all share that? Because that's exactly what you're talking about.
Well, I don't have my glasses on, but I will attempt to do my best. The title of this is Wake Up, Doc, by Christopher Vu, MD. Wake up, Doc, and try to stay calm for a while. Why are you always running from one place to the next, as if there is no life after tomorrow? What's your worry? Haven't you hurried enough all your life, trying to study and memorize, and all those silly facts of no real relevance? Wake up, Doc, and for a while, try to listen. Try your own heartbeat for a change, for if you do not know your own, it would be hard to hear your patients. Try not to think so hard, to figure out in your own head what is wrong with your patient. Sit down, hold his hand, look straight into his sad and weary eyes. Try to understand how he feels, because if you don't, then you might as well throw away all your textbook anyway. Wake up, Doc. Take a day off. Turn yourself into a beauty of Bach and Mozart and Chopin. Or watch a butterfly landing gently on a dewy morning rose. Take a quiet walk in the woods or along the seashore. Take a full minute to pause and ask yourself why $1 trillion of sophisticated machinery and powerful drugs are not easing the pain and suffering all around you. Wake up, Doc, and try to practice the art of medicine like you have never done before, because you will connect your heart to your brain and fill the hollow void between them. You will treat and treat, but can never heal.
Does that make sense?
Sure.
I hope I did it justice. I don't know if I...
Without the glasses, that's great.
little blurry.
Because, you know, I mean, that's exactly what I was alluding to, because there are publications now that allude to the fact that up to 70 or 75% of all information leading to a diagnosis can be derived from a good history and physical. But we have created a monster of medical industry where for many years patients were sent to the lab and x-ray before seeing the doctors. Wasn't that true?
Mm-hmm.
Yes.
And that, to me, that is really the reverse of, you know, of what we're talking about. Because if you sit down, take a good history, do a good physical exam, and order a few tests to confirm diagnosis, that's all you need to treat the patients. But we run from one patient to another, doing crazy things, you know, and spending all sort of money, and we treat and we treat and we treat, but we don't heal.
Well, I think the biggest reason that came about was for defensive medicine, that the patient in a litigious society were suspect, that if you had the patient who happened to be an attorney, you always did everything you could because you didn't want that patient who happened to be an attorney to come back and sue you for malpractice. So you really have taken common sense out of taking care of patients and tried to protect yourself from some vulnerability that is either real or imaginary.
Yeah.
And I think that, I remember hearing a lecturer talk one time. He was an orthopedist, and he was talking about how he couldn't afford not to do an x-ray every time he saw a patient. He couldn't afford it. And I made the question, if you can't afford it, why don't you get a better malpractice insurance company then? Because you should be able to justify why you don't do things as well as
I
do
also think the medical education in the United States leaves something to be desired in terms of much of the training is done by specialists who are technology-driven, high-tech oriented, and they focus in on ordering multiple tests and multiple scans when listening to the patient and listening to what the patient is saying is forgotten. And residents are told to order the battery of tests, order everything, and you're dinged in your training if you don't.
But why haven't we
everything.
taken the offensive instead of being defensive and treating our own fear? Why don't we go out and educate the judges, educate the lawyers, what quality medical care is all about? That's all they want too, for their patients and for themselves. To me, it's an educational process. You see, for a long time, we practice defensively because we're scared. So we treat ourselves, weren't we? I mean, we were afraid that, you know, if we don't have this, that, and the other, we may be sued. See, I was interviewing a doctor from Iran, and that's exactly what he said. He said, in training, they taught you to protect yourself from being sued. They don't train you to treat the patients.
But in certain situations, the patient's expectations may be unrealistically high. I mean, I delivered 500 babies when I was in practice, and every mother wanted a perfect baby.
Sure.
And so if you didn't follow the
Sure.
textbook rules of ordering the appropriate scans, the ultrasounds, the lab tests on an appropriate manner, and you didn't have a perfect outcome, you were set up for a lawsuit. Because the perception was every American baby coming to a fee-for-service doctor should have a perfect outcome.
But again, you know, he's talking about appropriate things to utilize, not quantity, but the right thing done at the right time. But that's why we're talking about quality medical care, how we define it. Does that mean, you know, all the tests on the table?
dimensions of quality.
And anybody can open a book and look at on the differential diagnosis and order all the tests. Does that cover you? I don't think so. It's a communication process.
But, for example, Hung, if you didn't order a scan and tell the 35-year-old woman that she could be offered an amniocentesis, and even if she turned it down, if you didn't document it in the chart that you offered it, she mandatorily turned it down, and the baby winds up with Down syndrome, the doctor is sued. The doctor didn't produce the Down syndrome baby, but if for some reason you didn't document, I have offered you the test of amniocentesis, and I hereby decline, and have her sign it in the chart, you're not practicing quote-unquote good medicine.
Well, I think that's documenting, you know, and this doesn't have any, I mean, I'm not an obstetrician, so I cannot speak
Right.
with expertise on a subject, but I firmly believe that is a lack of communication that creates so much anxiety because nobody knows everything, you know, but you see, I have this principle I dearly believe in, and that is if you care enough, you find the way to knowledge. You don't know everything, but you know, you can call this person, that person, and take care of your patient that way. But those who don't care will never know enough of what really matters.
Are you talking about the patient or the
care
physician?
providers. Care
Oh, okay,
providers.
the care providers.
Because oftentimes it's an ego trip. You know, in training, people really argue to win because they want to prove their intellectual prowess. That's what I'm talking about. To me, you know, that's you mentioning that people coming out of residency have somewhat of a unrealistic picture of what practice is about. There's really a dichotomy between the way we train, you know, to compete, to argue, you know, to win an argument. I often saw many doctors sitting here and talking about a test, and the patient is here. The patient's forgotten.
Well, one of the most important things that I think came out when I was on the chairman of the ethics committee was that a philosophy in physicians that they had to preserve life. And the problem is in terminal conditions that it's not an issue of preserving life as much as it's an issue of just delaying death. And in their training, their feeling was if a patient died, it was a failure on their part.
Right.
Even if you did everything correctly,
Yeah.
they're still expected to die. And
Yeah.
It's an issue of having to learn that they can give care and comfort measures
Yeah.
and help people through death instead
Yeah.
of being afraid of it
Yeah.
themselves.
It is important to help people
Absolutely.
dying peacefully. That, you know, I actually enjoy talking to you so much. We're running out of time again. You know, you have to come back some other time. I really enjoy this talk a lot. It goes very quickly. I hope that you enjoy being here and help promoting the idea that it's very healthy to have a communication, a dialogue to define things. Because I don't think there's too many of these kind of shows around. Do you think? So I am not trying to do a hard sell for this kind of show, but again, I think that this is very useful, and I hope that you continue to promote such endeavors. This is Dr. Vu. I'm finishing up this fourth part of the production on quality issue in medicine. Thank you for watching. So long. Good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near